Good evening. Today we will continue our discussion about the hereditary kidney diseases. This is part 3 for cystic kidney diseases. In part 1 we discussed autosomal dominant polycystic kidney disease, and in part 2 we discussed tuberous sclerosis. Today inshallah we will talk about autosomal recessive polycystic kidney disease, nephronophthisis, autosomal dominant tubulointerstitial kidney disease, or what is previously known as medullary cystic kidney disease, and medullary sponge kidneys. We will start by autosomal recessive polycystic kidney disease. Of course, we talk in part 1 about the most important one, which is the autosomal dominant polycystic kidney, and it is much more common. Autosomal recessive polycystic kidney disease is a disease of infancy and children, mainly in children. It is due to mutation of BKD-HD1 gene, BKHD1 gene, located on chromosome 6, encoding a protein called polydactyl. So again, it's due to mutation of BKHD1, including a protein called polydactyl, which play a role in the differentiation of the collecting duct and biliary tree. Autosomal recessive polycystic kidney disease usually affects the kidney and the liver, and the manifestations are chronic kidney disease, or CKD, and liver affection in the form of biliary malformation and biliary fibrosis, leading to congenital hepatic fibrosis. Congenital hepatic fibrosis, and the fibrosis mainly in the portal tract, and the liver parenchyma is usually intact till end stage. Congenital hepatic fibrosis leading to portal hypertension with its complications of splenomegaly and esophageal varices. It is much less common than autosomal dominant polycystic kidney disease, and the presentation is usually, and all the affected infants are usually diagnosed at birth, or in infancy by enlarged kidneys in ultrasound. Usually they have pulmonary hypoplasia at birth, with a perinatal mortality of around 30%. So what is our conclusion? A disease mainly present in infancy, usually leads to CKD or end-stage kidney disease in early life, associated with congenital hepatic fibrosis, in autosomal recessive inheritance, in a protein called polydactyl. Second one is nephronophthisis. Nephronophthisis is derived from the Greek language, meaning progressive loss of nephron, is usually inherited as an autosomal recessive pattern, characterized by tubulointerstitial nephropathy, tubulointerstitial fibrosis, and a very important cause and one of the most common causes of end stage in children and adolescents. It becomes manifested in children and adolescents, and a very common cause of end stage. It occurs at a much older age than autosomal recessive. We said that autosomal recessive polycystic kidney in usually in infancy and before 5 to 7 years of age, but nephronophthisis is usually a very common cause in children and adolescents. It is due to mutation in multiple genes called nephronophthisis. There are around 20 genes discovered, and the most important one is nephronophthisis 1. Nephronophthisis 1 gene that accounts for about 21% of all cases. 21% of all cases. And all of the remaining nephronophthisis genes, each one of them causes around 4% of all the cases discovered. Again, it is an autosomal recessive inheritance characterized by tubulointerstitial fibrosis and cystic. As we said, it is a cystic kidney disease. It is usually present, or its manifestations become in early childhood. leading to end-stage renal disease in adolescent, as we said before, mutations in nephronophthisis genes, especially the most common is nephronophthisis 1. In imaging, it gives a characteristic pattern of echo-bright kidney with few corticomedullary cysts. Again, this is a characteristic pattern. The kidneys are echo-bright, and few corticomedullary cysts. And due to its main affection for the tubules and the interstitium, it is mainly tubulointerstitial affection. So the main manifestations are polydipsia and polyuria. And usually it is a very common presentation for these children to present by polyuria and polydipsia, leading to end-stage renal disease. Usually they are associated with extrarenal manifestations, and the most important one is a senior Loken syndrome, when they are associated with the retinitis pigmentosa, usually leading to blindness in these children. The most common one is senior Loken syndrome, and when it is associated with retinitis pigmentosa, usually leading to blindness. Sometimes it can be associated with hypoplasia of cerebellum, causing what's called Joubert syndrome, and sometimes they are associated with bone abnormalities. The third one is the autosomal dominant tubulointerstitial kidney disease. Tubulointerstitial kidney disease. It is similar in its affection to nephronophthisis, but it is autosomal dominant. It is autosomal dominant tubulointerstitial kidney disease. It is a new term. It is usually have been described for a long term as medullary cystic kidney disease. And it is a famous name, medullary cystic kidney disease. So autosomal dominant tubulointerstitial kidney disease has been previously described as medullary cystic kidney disease, or also a new name, uromodulin related kidney disease. This is a new name. Take care of that. Uromodulin related kidney disease. So it has three names. It is usually due to mutations in 4 genes, or mutations in 4 genes have been discovered in this disease. MUC1, uromodulin, RAN, and HNF1B. And hyperuricemia is a very important feature, especially with the uromodulin related cases. We said there are 4 genes and uromodulin is one of them. And when uromodulin is causing that disease, hyperuricemia is a common feature. Talk in depth about this medullary cystic kidney disease, or autosomal dominant tubulointerstitial kidney disease. It is inherited as an autosomal dominant pattern. Unlike in nephronophthisis is autosomal recessive. This is autosomal dominant. It is usually present in a much older age group than in nephronophthisis. Nephronophthisis is in adolescents, but this medullary cystic kidney disease usually present in or manifest in adulthood with progressive renal impairment or CKD. The affected gene, as we said, there are around 4 genes, but the most important one is medullary cystic kidney disease 1 and 2. Medullary cystic kidney disease 1 is the MUC, and medullary cystic kidney disease 2 is the uromodulin. These proteins have a very important role in the renal cilia. Usually it is manifested by, or in imaging, there is a small cyst at the corticomedullary junction, small cyst in corticomedullary junction. It is usually also like the nephronophthisis. It is usually characterized by severe tubulointerstitial inflammation and scarring. severe tubulointerstitial inflammation and scarring. Usually, the affected individuals have a positive family history. As we said, there is autosomal dominant pattern, and due to like nephronophthisis, due to this main affection to tubules and interstitium, they usually present by nocturia, polydipsia, and polyuria. Nocturia, polydipsia, and polyuria. And the urine is usually bland with no proteinuria or RBCs, and the blood pressure is usually normal. The ultrasound usually revealed small to normal sized kidneys, and CT usually is very good in illustrating these small cysts. Usually they are associated with hyperuricemia, especially with uromodulin or medullary cystic kidney disease 2, and CKD usually progress to end-stage renal disease by the age of 60, and uremia, as we said, it usually occurs after 60 years of age in medullary cystic kidney disease 1 or the MUC1 gene mutation. But in uromodulin or medullary cystic kidney disease 2, usually it can occur between the 4th and 7th decade of life. The last one in our talk today is the medullary sponge kidney. Medullary sponge kidney. It is the most important information to remember about it. It is a benign condition. Don't forget, it is a benign condition. Usually, it is not associated with renal impairment. It is characterized by medullary cysts, or the cysts are mainly present in the medulla. There is no family history. The main presentation is recurrent UTI and stone formation due to impaired calcium handling in the collecting duct. Impaired calcium handling in the collecting duct leading to formation of calcium stones, recurrent stones, and we should consider it for any patient who presents with the recurrent stones and recurrent UTI. The cause might be a medullary sponge kidney. Again, we should consider the diagnosis in young patients presenting with calcium stones. Hematuria is a common presentation. Hematuria can be present with stones or without stones. And recurrent UTI is a very frequent finding. Diagnosis is made by imaging. Traditionally, in the past, it was mainly on intravenous urography with a typical caliceal brush or paintbrush finding. But now the main imaging modality for diagnosis is CT. Renal impairment, as I said, is very rare, and management should be directed at infection and prevention of stone formation, especially with the use of potassium citrate. This is picture of intravenous urography giving the paintbrush appearance. Paintbrush appearance here. Paintbrush appearance. And here in CT, the calcifications are mainly present in the medulla, as we see here. It is not in the cortex, it is mainly in the medulla. This table is important for differentiating between medullary sponge and medullary cystic kidney disease. As we said, medullary sponge at any age, but medullary cystic usually between 20 and 30 years of age. The presentation, but the CKD or end-stage renal disease is usually between the 5th and 7th decade, and CKD or end-stage renal disease can occur with medullary cystic, but it usually doesn't occur with medullary sponge. Again, don't forget that medullary sponge is benign, but medullary cystic can lead to end-stage kidney disease. Medullary sponge can be associated with a salt-losing state. As I said, it is mainly a tubulointerstitial disease associated with polyuria and nocturia and polydipsia and salt losing. The main affection in medullary sponge is recurrent stones and recurrent UTI, and in medullary cystic it is an autosomal dominant inheritance, so a positive family history is present. This to summarize our talk in cystic kidney disease. This table is very important, containing all the information that we should need. Autosomal dominant polycystic kidney, as we said in part 1, autosomal dominant, of course, there is a family history, and usually it leads to CKD, and patients are usually hypertensive, and cysts are mainly present in the cortex. The first three are cysts are mainly in the cortex, while the others are mainly in the medulla. So in autosomal dominant, it is autosomal dominant, so we have a positive family history, and usually it leads to CKD and end stage, and hypertension is usually present. Juvenile polycystic kidney disease, or the autosomal recessive polycystic kidney disease, as I said, it is usually diagnosed at infancy or before the age of 5 years. Of course, it is an important cause of end-stage kidney disease in infancy, and they are usually hypertensive. Simple cyst, it occurs in elderly population. In elderly population, it is mainly in the cortex. Medullary sponge, as I said, it is a benign condition characterized by recurrent stones and recurrent UTI, and it is not associated with CKD or hypertension, and there is no family history. Medullary cystic kidney disease, or the autosomal dominant tubulointerstitial kidney disease, it is an autosomal dominant, so there is a family history. It is an important cause of CKD between the fifth and seventh decade. Usually there is the blood pressure is normal due to the main affection of tubules and interstitium, and usually they are present or presented or manifested between 20 and 30 years of age. And of course, the cysts are in the middle. Nephronophthisis, it's also a tubulointerstitial disease, autosomal recessive inheritance. It is one of the most common causes of end stage in adolescents at the age of 15. It is autosomal recessive, an important cause of end stage, and again, blood pressure is usually normal because it is a tubulointerstitial affection. It can be associated with extrarenal manifestations, especially senior local syndrome when it is associated with retinitis pigmentosa. Very important table that summarizes all the cystic kidney disease and the peculiar feature of each one of them. This is our resources, and